Good evening, doctors. Welcome to this year's WebQuest 2020 webinar, which is a very special occasion with the virtual launch of the book written by eminent neurologist from Kolkata, Dr. Amber Chakraborty, whose book, Mimics of Epileptic Seizures, holds immense value for all practicing neurologists in the country. I am very grateful to the eminent epileptologist speakers today, Dr. Joy Desai from Mumbai, Dr. Nandan Yardi from Pune, and Dr. Vinayan from Amrita, Cochin, who will be making this EpiQuest 2020 virtual program a truly enriching one. I now invite Dr. Joy Desai to begin this program by launching Dr. Amber Chakraborty's book. Dr. Joy Desai.
Thank you, Michael. Good evening, everyone. It's a great honor and a privilege to be part of today's program to launch the book written by Dr. Amber Chakraborty, conceptualized by him, many chapters written by him, with various other luminaries across the country. From the time that I've been a student, when I first entered the hallowed portals of neurology and looked up to great eminent teachers like Professor Sarosh Katwar, Dr. Anil Desai, Professor Wadia. All of them, in my opinion, had a very high opinion of the caliber, the academics, and the academic prowess of Professor Amber Chakraborty. And I have personally been a great fan of his writings, his lectures, and his contributions all across these years within the IAN, the time when he was the president of the IAN, and it's an honor and privilege to participate in today's launch. In the past, I have been writing in previous editions of some of his books, and as you will see, this book is a probably become mandatory reading for most of the neurologists in training and neurologists in practice, as it's a wonderful compilation of seizure mimics. I hold in my hand the packaged version of the book, and it's a great honor and a privilege to launch this book for Professor Amber Chakraborty today. And I'm hoping that every neurologist in the country, the ones who are practicing and those who are in training, will have access to this and will be able to derive immense knowledge and pleasure from partaking of the contents of this wonderful book. Let me quickly cut through the packaging and show you the So this is this wonderful book, Mimics of Epilepsy and Seizures, and the salient features of the book have been synopsized on the rear of the book by Professor Chakraborty, and the contents are by many eminent epileptologists across the country, as I said. And I'll now like to invite Professor Amber Chakraborty to speak a few words about his ambition and his thought process in contributing immensely to neurology in India with the number of books, the one which has already come out and one I believe is in the making to come out soon. Thank you, Professor Amber Chakraborty.
Thanks, Joy, for the very kind words you said about me. Our friendship goes several years, I would think a couple of decades at least. And your predecessors at Just Love, Professor Nashir Wadia and Sarosh Katwar, had very good relationship with both of them. Great regards for Professor Wadia. And Sarosh is a very good friend of mine, as you know. I'm really grateful to Dr. Michael D'Souza for arranging this program webinar to launch this book because the books are usually launched during the annual conference of the Indian Academy, but this year there won't be any iron con, so we discussed. And then we thought we'd do a webinar during which the book can be launched. So I'm really grateful to him. I'm also grateful to the publishers, JP Brothers Medical Publishers, because the entire compilation of the book, which was quite difficult, was done by working from home. I was in Calcutta. They had one person in Calcutta, but he was staying outside the city somewhere. And there was a lady in Delhi, and there were other people in Mumbai. So we have been all coordinating to get the thing done. What I wrote had to be done there, then edited and all sorts of things, then videos to be incorporated. Some massive task which we completed. I submitted the manuscript to the publisher end May, and within the next 2 months, all the things were ready. In between, there are lots of videos and all sorts of problems going on because the whole thing had to be done from home. Anyway, it has been a great endeavor, and I hope people for whom this book has been written will enjoy it, will learn from it, will try to practice whatever we have thought is important for neurologists to know. The book contains 22 chapters, 21 commentaries, about 25 case studies, and another 25 or 26 video clips. So it's quite a big thing, and it took a lot of effort to do it. The reason for bringing out this thing is I have a very long fascination for the conditions which mimic epileptic seizures, from which it has to be differentiated to make a diagnosis of epilepsy. That's an exclusion diagnosis. Of course, there is a positive diagnosis of epilepsy where you find evidences in favor of epilepsy and diagnosis. Now, I was attracted to it some 40 years back when I was in training in UK, when I first read William Gower's book, Borderland of Epilepsy. This is the first time I read that book. I now possess a book for the last 20 years or so, and I go through that several times. In fact, I made an attempt to write a book which was more or less a somewhat plagiarized title called Borderlands of Epilepsy. For various reasons, including financial, it was not a great success, but still I know some people do have this book and occasionally goes through that. The present one is basically a very much updated version of the same book. And of the chapters, there are 2 historical chapters. One is on the life and legacy of Sir William Richard Gower. Another one is on hysteria, a very favorite topic of mine, and I have tried to trace the changing concept of this problem, hysteria, from ancient times to the 21st century. So that is an historical article which people will love to read, and as many people know, I've got a lot of interest in history of neurology. I know that this webinar is being attended probably by many young neurologists and neurologists in training. And I just want to say 1 or 2 words for them to help them carry on with their career for the rest of their lives. And the first one is the most important thing about neurology is clinical neurology. And it is said that if you cannot make a diagnosis by the time you complete listening to the story of the patient, you will never be able to make a diagnosis, even after examining him 10 times. That is probably true in 99% of cases, maybe not in 1%. And I can see now how important this is as I'm practicing telemedicine for the last five or 5.5 months. Because I cannot examine the patient, I can only listen to the patient or read whatever he has sent me by WhatsApp and have a chat with the patient, see him, ask him to walk, sit, stand, all these sort of things, but can't touch him. So that, I think, is the height of learning. The second thing I always tell youngsters is, a lot of people reads a lot of things, grabs a lot of knowledge, but that ultimately becomes meaningless unless you think about it. So I tell the students when I used to regularly teach, and I tell my younger friends, read less, think more. Try to find out concept, conceptualize the thing, and then only you can quickly reach to the core of the problem a patient comes or presents to you. So with that, I will finish, and I hope this webinar with the three very important speakers would go on well. We will learn from it, and I should be most grateful to Mr. D'Souza, who has not only organized this symposium, but also promised me that we'll make sure that the book reaches every member of the Indian Academy of Neurology, as well as the PG students, free of cost. The book is also available on the web, will be available, where you can see the videos, and so that would be very helpful. Thank you very much. Have a nice evening. Thank you.
Thank you, sir.
Thank you, Amar. It was wonderful to listen to you as usual. Michael, should we proceed with the program for the evening?
Yes, sir. I request you to please begin this session, sir, academic session, with your topic, when others masquerade as seizures. So please do take the honors of beginning with this topic.
Right. So if you'll allow me from the support systems, I will share my screen.
Yes, sir.
Super. Thank you. Is my screen visible to everyone?
Yes, sir.
Yes, sir. Yes, sir.
Right. So at the outset, let me thank everyone for asking me to participate in today's proceedings. And it's also my rather sad duty to tell you that Dr. Sangeeta Rawat had actually conceptualized today's evening, and she had put together today's program. Unfortunately, her parents were ailing this week, and she lost her father this morning to COVID, and Dr. Rawat could not make it. So before we start, I just wanted to convey our heartfelt condolences to Dr. Rawat and her family in their very difficult time. About where the mimics of seizures, and I feel very humbled when I stand before Professor Ambar Chakraborty here today, talking about conditions that can masquerade as seizures, because he's managed to write a whole book on it, and that too a book which makes very good reading. It's been on my desk for the last week since the time I got it, and in these next 25 odd minutes, I do not wish to go through a whole didactic lecture on the different conditions that can masquerade as seizures. You heard Dr. Chakraborty wisely tell younger people to think more and read less. Perhaps I would say to read much, but to think much too. And what I shall try to do is to give a little broad overview of the common conditions that sometimes confound us in the clinic when dealing with what looks apparently like seizures, and then share with you three cases which changed the way I thought about seizures in my practice. And I hope you enjoy listening to the story as it unfolds in these three patients, as much as I have done looking after them and tracking down their very peculiar genesis of seeming seizures. So, Michael, moving forward, do you want me to log out again and log in again? Yes. So appearances are often deceiving. We know that, and the same is true for many neurological conditions. More so for conditions that are associated with episodic events. So if one looks at episodic events in the ward versus in the ICU, the underlying suspects can sometimes be somewhat different. In the clinic and in the wards, seizures and their subtypes form an important subset of individual patients who seek medical attention with episodic events. Then the other contenders that may confound such an analysis are syncope, very commonly a common differential of seizures, migraine, sometimes transient ischemic attacks. And we know that in some individuals, which you'll read about in Dr. Amber Chakraborty's elegant book, experience what is called limb shaking TIAs. So they have TIAs due to a very severe carotid stenosis. And every time there is hypotension, the hypotensive episode triggers a curious mix of electrical dysfunction within the cerebrum and produces manifest symptoms in the opposite limb with shaking of the limbs due to a transient ischemic response and what is classically called a limb shaking TIA. And that can form sometimes a important differential of individuals who seek medical help for seeming repetitive episodes with movements in a lateralized part of the body. There are numerous sleep disorders that can mimic seizures, and I hope to share some of them with you tonight. Then there are paroxysmal dyskinesia, and along with paroxysmal dyskinesia, there can be seizures themselves. And one of the commonest clinical scenarios wherein seizures and paroxysmal events can be precipitated. We were all taught in internal medicine that hypoglycemia can commonly trigger a seizure. But if you really see patients who have diabetes, then hyperglycemia perhaps more commonly triggers an episodic event in the brain. Often it can present with paroxysmal dyskinetic movements due to very peculiar changes that occur in the putamen and the caudate nucleus in the striatum. And in some individuals, it's been well documented that you can have seizures as the presenting manifestation of a sudden rise in blood sugar without ketosis. So you can have non-ketotic hyperglycemia presenting with seizures. There's transient global amnesia, and the bane of every epilepsy clinic are paroxysmal events that are psychogenic in origin. And you heard how Dr. Chakraborty has always been fascinated by his theory, and he talks about psychogenic events, and you'll be able to glean more about psychogenic non-epileptic events, and we now call them psychogenic non-epileptic attacks rather than seizures, because the word seizure seems to confiscate the issue and call them seizures. They are not really seizures, they are episodic events that arise due to a psychogenic disturbance. And vestibulopathies can also sometimes be mistaken for seizures in the clinic. In the ICU, when we deal with status epilepticus, you can have provoked and unprovoked seizures, which are a confounder, provoked from a metabolic disorder, myoclonus from a variety of causes, degenerative underlying brain disease, the manifest effects of certain drugs and antibiotics, cefepime to name a few, seizures emanating from commonly used antibiotics today, like say ertapenem or the carbapenem groups like meropenem. You can have fluctuating encephalopathy. You can have press or reversible posterior leukoencephalopathy syndrome, as it was originally called. Sometimes the differential can be genuine seizures, but with the grave import underlying of the need to recognize limbic encephalitis and esoteric conditions like carcinomatous meningitis. So clearly, the neurologist has a lot to contend with when looking at conditions that can mimic and look like seizures. So, as Dr. Amber Chakraborty told you in the beginning, it's the history, and the history that is most relevant. Now, unfortunately, the history is relevant entirely agreeably, but when we're dealing with seizures, we have to rely on the eyewitness account. And the analysis of what the patient is undergoing to the trained neurologist, to the trained epileptologist may not be difficult because they are well versed with semiological understanding of different semiologies, how they relate to particular parts of the neuraxis that are involved in the network generating seizures. However, when we rely on the eyewitness, it is limited by many factors. It's limited by their level of education, by their observational prowess, and by how they see the value of a holistic description. Many of the patients may have seen the whole event, their caregivers may have seen the whole event, but they are compounded by the salient factors, and they only talk about the tonic-clonic event, and they forget to say what they saw preceding the tonic-clonic event, because to them, those subtle seizures, those subtle ictal events may not have been of great import because they're not trained neurologists. So at the bedside, sometimes in terms of seizures, analyzing entirely on the eyewitness account can be sometimes a challenge. One of the commonest differential diagnoses, both in sometimes maybe not so in children and adults, but in the elderly, is syncope. And we know that syncope is often is the first thing that we think about when we are seeing these patients. Is it a seizure? Is it a syncope? And from many years, we know from literature that there are very standard clinical criteria that we deploy in differentiating one from the other. So we have a rating score as well, which was proposed by Sheldon, that was published in 2002 in the Journal of American College of Cardiology. And one can designate points to commonly elicited clinical features. Was there did the patient wake up with a tongue that has been bitten or which has been cut? And you can designate 2 points for that. Did the patient talk about a sensation of deja vu or jamais vu? Is there an emotional stress that is associated with loss of consciousness? Is there a head turning during a spell? Is the individual unresponsive? Is there an unusual posture, limb movement, or amnesia for the spell? You give it one point each. Is there a confusion after a spell? You give 1 point each. But if the individual patient speaks about lightheaded spells, you deduct 2 points. If there's sweating before the spell, you deduct 2 points. And if the spell is associated with prolonged sitting or standing, you deduct 2 points. And if the point score is greater than or equal to 1, it's likely to be a seizure. If the point score is less than 1, then the likelihood is of syncope. This actually is just a numerical arithmetic translation of what we commonly ask for. And we know that the presence of sweating is an important marker. We do not expect a patient with a seizure to sweat during the event. And we do not expect a patient with a seizure to feel like defecating after an event. So if a person has felt like defecating after the event is over, it more likely points to a syncope. Though we know that urinary incontinence and a tongue bite, or that to a lateral tongue bite, is an important hallmark of the genuineness of the event likely to be a given seizure. And there are numerous publications that have talked about the value of utilizing clinical markers and the value of utilizing video EEG data when we have a patient who's on the fringe of such a condition. One of the things I learned early, which was really not taught to me when I was a student, because in our neurology curricula, we often don't teach too much about migraine. I don't know what the others feel, but I felt as a student, definitely, that we learned about very esoteric things like prion disease and the classifications of spinocerebellar ataxia, for example. But many of us did not discuss at great length in our studentship days about migraine and the various ways in which migraine can manifest. So this very seminal study, the population-based camera study that came from the Netherlands, which was published in Neurology in 2006, was aimed at looking at the prevalence of syncope, orthostatic intolerance, and orthostatic hypotension in patients with migraine. And if you look at their data that came out, this is the table. And what you see here on the left is migraine overall, followed by migraine with aura, migraine without aura. And that's the numbers. Their total number was 323. And it's an equal spread, 174 migraine with aura, 149 migraine without aura. And greater than one migraine attack in a month in 156, less than one migraine attack in a month in 167. And look at the frequency of syncope. Syncope ever in terms of percentage varies from 50% and little above. But frequent syncope, if you see here, seems to occur in a good 10 to 15%. So it's very clear that sometimes a patient who has migraines and never talks about their migraines comes to a neurology clinic with a history of episodic loss of consciousness, being evaluated for seizures. I had a patient who had gone to Australia and went to Melbourne and underwent video EEG, numerous EEGs and evaluations for her episodic loss of consciousness, one of which occurred on her flight. And when she came back to Mumbai, the sterling thing that came out was the fact that she never talked about her migraines to the Melbourne team. And they thought they were psychogenic events, but she turned out to have severe migraine with episodic syncope. So that can be an issue. And I think it's something important to remember because migraine is a very important, very common clinical condition in the community and amongst the populace of patients seeking attention in a neurology clinic. Of course, we all know that psychogenic non-epileptic events are a condition by themselves. Patients who have seizures can often have comorbid psychogenic non-epileptic events. It's a cascading cycle of dependence on the behavioral gain from having had a seizure. There are numerous theories as to how it emanates, and it needs to be differentiated from the true events. So sometimes a patient who presents with seemingly refractory epilepsy despite being on medication with numerous recurring events, one may have to wean off and differentiate psychogenic non-epileptic attacks amongst the genuine ones as well. And we know that Salim bin Badis and others have written extensively about it. We know that there are features, historical features, which have been delineated. Um, Very high frequency of seizures that is completely unaffected by medication should give us a red flag. Specific triggers that are unusual for epilepsy, stress, getting upset, pain, certain movements and sounds, and especially if seizures tend to occur with an alarmingly increased frequency in the doctor's chamber or in the doctor's waiting room, maybe a marker for the fact that this may not all the events may be genuine and some of them may be psychogenic and comorbid numerous other poorly localizable symptoms, which may suggest to some form of somatization, should also raise the suspicion. Obviously, when one analyzes these patients, the psychosocial history, including psychiatric diagnosis and their background and their childhood psychological background, is relevant, and one may need the assistance of a psychologist to uh, delve into what is ailing the patient's mind and resulting in those frequent events. So we know that there are numerous events, and if I sat here, I could talk through the whole evening, but I do not wish to do that because you have the lovely book by Professor Chakraborty to read. And what I wish to do today is to share with you some cases that I thought changed the way I thought about recurring seizures in an epilepsy clinic. And I wish to present three cases to you. This is the first one, which I have presented in the Indian Epilepsy Society meeting in the past. This is a male 37 who owns and manages a granary shop in Madhya Pradesh. He sought a second opinion for recurrent and devastating seizures at the epilepsy clinic at Jaslok Hospital. The patient was born at full term with a normal perinatal background. Infancy, childhood, and development were normal. At the age of 31, he experienced a generalized tonic-clonic nocturnal seizure at 5 a.m. in the morning, and he dislocated his right shoulder. He had a mesomorphic habitus, and at this time in Madhya Pradesh, in Indore, he actually saw a physician the next day. The physician examined him. CNS examination was unremarkable according to notes, and a brain MRI was done and an EEG were done. Both of them were deemed to be normal by the reporting specialist. He denied a family history of epilepsy, but he was terrified of any future recurrence because he had a very painful shoulder after the dislocation. And his local neurologist, despite the fact that the MRI and EEG were normal, had no choice but to prescribe him an anticonvulsant because he was completely petrified of having another. So he was asymptomatic for 18 months, and both the patient and his physician thought that they had won the battle against what was ailing him. He was compliant with the anticonvulsant, which at that time was phenytoin, and lo and behold, he had another nocturnal seizure. And this time he fractured his D9 vertebral body with a very severe backache due to D9 vertebral body. He saw an orthopedic surgeon, and the orthopedic surgeon had to do a vertebroplasty to allay his pain. This time, a sleep-deprived EEG was done, two neurologists were consulted, a protocolized MRI with a 3T machine was done, and all of them were normal. An autoantibody screening was done to rule out autoimmune epilepsy. The biochemistry and hematology tests were done. They were all clean. The local neurologist, because the patient by this time was very convinced that under no circumstances did he want one more seizure. So he was forced to add levetiracetam to phenytoin. And that was at that time in the early 2000s, the drug that everybody liked. And the patient's fear was escalating, so levetiracetam was added. The patient experienced drowsiness but continued to comply due to fear of seizures. And look at that. He was good for 28 months, and 28 months later, after a long period of time, he has one more nocturnal seizure. And this time he breaks his left patella. And this requires arthrodesis. And this is completely the truth. This is the way the patient actually broke a bone with every seizure that he had. And this time for the arthrodesis, he came to Mumbai and he came to see one of my senior orthopedic colleagues. And Dr. Modi said that we better see the epilepsy clinic first. I don't know what's going on. So the only critical thing on examination was that he had a Friedman score of C when I looked at him physically and I looked at his oropharynx, examined every patient. And when we took his sleep history, his wife confessed that he had been snoring since marriage. And she said, कि अब तो sir वो रात को 5वीं gear में truck चलाते हैं. He drove a truck in 5th gear according to her while sleeping. He was so noisy, and because he had recently gained weight. And the patient said yes on questioning that he had daytime drowsiness, fatigue. He woke up feeling drained. He wanted surgery for his epilepsy. He was actually asking me for surgery. And he was tired of taking anti-epileptic drugs and he didn't want to break another bone. And this is the Friedman staging system. As I can show you, there's A, B, and C, and you can clearly see that when the soft palate is not visible when you open the patient's mouth open, is Friedman C. And we know that if it is associated with a BMI of a particular reading of less than 40, then it can be associated with a high risk for obstructive sleep apnea. This patient underwent a polysomnogram in 2014 when I'd seen him with a PSG system. His sleep efficiency was 90%, and you can see that he had 266 episodes of apnea hypopnea, giving an AHI of 43 per hour of sleep. His REM AHI was 69 per hour of sleep. He had predominant apneas in supine and right lateral position, and his longest duration of apnea was 98 seconds, and he had hypopnea for 52. He had 77 episodes of significant desaturation, and the average saturation was 95, the lowest was 84. So when on the 22nd, then we did auto CPAP trial, and at a pressure of 9 centimeters of water, his AHI was reduced to 4 hours. So this patient, and of course, regrettably for me and unfortunately for him, he did not have a seizure during the sleep study, and the EEG during the PSG was normal. A prolonged sleep-deprived EEG was done again at Jastoke, did not show any potential epileptogenic EEG abnormalities. He was counseled about weight loss and he was started on CPAP. And it's been now more than 60 odd months post CPAP. He's been in touch with me. He's had about 3 follow-ups. He doesn't follow up anymore because he's event-free. He refuses to go off his anticonvulsants. So we gradually weaned off his phenytoin. And he did not want to take levetiracetam off because he's petrified of seizures. And he's continuing his CPAP. And his daytime alertness is significantly better. And his sleep satisfying. So this was one case that got us thinking. And the second one was slightly different. The second patient is a 52-year-old businessman, resident of Bandra, Mumbai. He experienced a generalized tonic-clonic seizure at 4:45 in the morning, which resulted in a severe tongue bite and a dislocated left shoulder. And he was accompanied by his wife, and his wife narrated that, sir, he became still and blue, and I thought he had died. And then he snorted, then he cried out and started shaking violently, only to fall out of bed and involuntarily wet his clothes. 7 years ago, he had had a similar episode at night. At that time, he was evaluated in another hospital, in one of the hospitals in the suburbs. And EEG and MRI were normal. He was prescribed phenytoin, which he took religiously for 3 years. And then since he remained normal and his EEG MRI was again normal, after 3 years, the phenytoin was discontinued. He sold digital equipment for a living. He weighed about 118 kg. He was sedentary. He loved vada pav and Coke. He said he would have 2 to 3 Coca-Colas every day and would not walk to the dining table if he could be fed on the TV couch, was the narrative that his wife said. So really, he clearly had, this one was different from my other patient. He had a Pickwickian habitus, exhibited no focal signs. Epilepsy protocol MRI was normal. EEG sleep deprived was normal. Routine blood evaluation was normal. And this event too was at about 4:45 in the morning. His wife confirmed a history of snoring, daytime drowsiness, general lethargy. So the infrequency of seizures, the absence of daytime seizures, the wife's narrative of cyanosis preceding the seizures raised the possibility of hypnic hypoxic seizure on a background of OSA since he had the phenotype. And if you look at his study, he had an apnea hypopnea index of 47 per hour. He had a significantly period of time. He had significant oxygen desaturation, 301 episodes, and the lowest was 62. He spent 69 minutes of his sleep in severe oxygen desaturation, less than 90%. And look at that. His longest duration of apnea was 142 seconds. I almost fell out of my chair when I saw that. You can imagine this is more than 2 minutes. It's not surprising that his wife thought he nearly died when he stopped breathing. So he's been on BiPAP and he's done very well, and he has not had further events. So what are the cardinal features in these two patients? They had infrequent seizures. You can see in the first patient long periods of time, year and a half, more than 2 years between his seizures. All were essentially nocturnal, predominantly in the timings of REM sleep in the early morning hours. No daytime seizures. Propensity to occur in the early morning hours during REM sleep, where it predominates, as does OSA. They had bodily habitus which enhanced vulnerability to OSA. And they had all normal basic investigations for epilepsy done more than once. And the key thing was there was a stark failure of primary care doctors in eliciting their sleep history. So the question is, can epileptic events be linked to obstructive sleep apnea? And there is very, very little literature on this. This is a patient who actually had seizures and who also had comorbid OSA, had a very high body mass index of 44. She was evaluated by Michel Bolac in Paris and Sophie Dupont. And accidentally, when this patient was undergoing video EEG, they were able to understand that there was an electroclinical event in this patient when the patient had a K complex followed by a microarousal and an apnea, as you can see here in the loud snorings and the breathing arrest, as shown here in the lower part of the graph. At that time, the patient was developing a bisynchronous, symmetrical spike and wave discharge. And this was taken away when they put the patient on CPAP, and it did not happen. And when they took CPAP away, this rhythm reappeared. So the authors found seizures preceded by OSA and microarousal. There was an unexpected interictal rhythmic generalized slow wave and sharp wave discharge related to OSA, which disappeared under CPAP and re-emerged when it was withdrawn. And the authors make a point that this is a result perhaps of bilateral synchrony and not a primary generalized epilepsy signature. And this, of course, is a single case report, and I do know, but it possibly sheds some light on the fact that maybe in some people who have severe OSA, if they have vulnerable electroclinical activity in their thalamocortical networks and circuitry, it could result in events that trigger a genuine seizure and can mimic what looks like nocturnal epilepsy. And my final case is slightly different, and another patient who made me think differently again. This is a 58-year-old accomplished, successful interior designer, expanding his business to regions in the US. He started staying awake till about 2 to 3 o'clock as a routine. And he kept telling me that, Doc, I don't need much sleep. He's the brother of an eminent urologist who's a friend of mine in Mumbai. While at LA for work, he collapsed on the dais while lecturing, and he was transferred to the emergency medical service. He was found to have sick sinus syndrome, and he was implanted with a permanent pacemaker. And on returning to Mumbai, he kept saying that his brain disconnects from my body, Doc, numerous times in a day. And when he kept saying this to his brother said, go and see Joy, and he landed up in the clinic. So he was sitting up, no change in posture, no sweating, no visible automatisms, conscious. And he says to me, hey, sir, it's happening, my body's gone. And the episode lasts for less than 10 seconds. Very quickly, he says, oh, it's gone, and it's gone away, I'm feeling better now. So we did his MRI, we did a 12-hour EEG. There were no spikes during the episodes. We did a video EEG, couldn't find anything there. There was only some little bit of asymmetric slowing in the temporal region, which we thought was, couldn't put any import to that. He had gained 15 kg in the last 4 years. His wife confirmed that he was a heavy snorer. He had been snoring since we were married, but is much louder now, Doc. He works hard and parties harder. And in weekends, he binges. So he told me that he likes his vodka. And weekends, he has 7 to 9 vodkas with pals on a weekend. Yes, I feel tired most of the time, but I don't have time to exercise or to sleep, actually. I have a very, very busy career and business. When we did his PhD, he had severe sleep apnea with an AHI of 55 per hour. And at a titration of 10 centimeters of water, his AHI resolved to 3 per hour. And his bodily dissociations disappeared. Those episodes, 7 to 8 of them that he claimed were happening to him, disappeared. Many of the physicians who had seen him had not thought about microsleep intrusions as a possible explanation for his bodily dissociation. They thought that he was functional. But I think we should worry about microsleep in a story like this. So microsleep can be a marker of not very apparent sleepiness in patients with obstructive sleep apnea. So there is, often in patients with OSA, there is a peculiar phenomenon in the sleep-wake transition. And in very regional small parts of the brain, there may be episodes where the EEG activity deep down in the brain becomes like what happens, slows down like in sleep. And microsleep has become a big concern for daily performance tasks such as driving, and it can result in potentially fatal accidents. And there's a huge interest in analyzing this because these episodes of microsleep cannot be picked up on a standard scalp routine EEG. And there have been numerous research studies that have aimed at trying to tap these microsleep episodes on an electroencephalogram. And very recently, just about a couple of months ago in this year, there's this lovely paper by Hertig Goshals from Switzerland, and they have come up with a scoring system which is called the Burn scoring system, which is on an automated device that looks at sleep-related slowing on an automated basis on a multi-array EEG with 64 and more electrodes on the scalp. And that may become the industry standard in time to come. So the take-home messages are that seizure mimics are many and myriad conditions can masquerade as seizures. Many of them we know, and the neurologist has his job cut out when eyewitness accounts are limited by circumstances and observational bias. Even when eyewitness accounts are very graphic, it may be sometimes difficult. We have criteria that can distinguish syncope, psychogenic events, limb shaking TIAs, hyperglycemia, associated focal paroxysms, and it may not be very difficult in that. Awareness of sleep-related disorders producing transient infringement in wakefulness and altered thalamocortical cyclical harmony now perhaps will add to the conditions that can masquerade as epilepsy. And in busy clinics, I think it's important that we also take sleep histories and make sure that when we don't understand what is happening to the patient, we ask other questions about what could be the mechanisms that lead to a transient disruption of either their sleep-wake transitions or their electrothalamocortical circuitry balance, resulting in what looks seemingly like seizures. I think with that, I shall stop. And I'm very grateful for all your attention during the last half an hour. Thank you very much. Michael?
Yes.
Yeah,
So we will be taking the questions at the end.
Yes.
So we will now call upon Dr. Nandan Yardley.
Can I stop sharing?
Yes,
Yes,
sir.
please, sir.
Yes, thank you. So I've stopped sharing my slides, and I think it's my privilege to ask Dr. Nandan Yardley. We know Dr. Nandan Yardley. He's an eminent epileptologist in Pune, and he's very active both nationally and internationally. He has been recognized for his numerous efforts and contributions globally at the ILA, at the American Epilepsy Society. And he's not only well known here, he's very well known in the international circuit too. And today, Dr. Yardley, despite being in Kentucky in the US, has very kindly consented to participate in today's program. And he's going to speak to us about the positioning of newer AEDs in the treatment of epilepsy. And I can assure you that we will have really enjoyed listening to him tell us. Dr. Nandan Yardley. I shall mute my.
Hello, am I audible?
Yes, sir. Yes, sir.
Is my slide also seen?
Yes, very, very clear. Yes.
Okay. Thank you, Dr. Joy, for the kind words of introduction. And it gives me great pleasure, and it's a big honor for me to be here at the launch of Professor Ambar Chakraborty's excellent book. We learned from him that the history taking is most important in the diagnosis of seizures and differentiating from non-epileptic or non-seizure paroxysmal events. And this was very well exemplified by the fantastic talk that Dr. Joy Desai gave us and showed us 3 examples where history taking and the pointers in history could be most important to differentiate this. Now, it's one of the most challenging talks of a person, of a clinician, where a patient enters his clinic with a history of paroxysmal event to differentiate non-epileptic events from epilepsy. And this can really be the Waterloo. Once you have got through this step, rest of the things are very easy because you can read about anti-epileptic drugs in the books and from listening to lectures and so many other things. And you can just apply all that and you will do pretty well in controlling the patient. But this book really exemplifies and as Professor Chakraborty has included videos that will be take everyone very far in learning about how to differentiate these seizures from the non-epileptic events. And I congratulate him on this book. And as I know Professor Ambar Chakraborty is a great teacher, I've always loved to interact with him at various conferences and otherwise. I sometimes call him otherwise also and talk to him because he's an original thinker. It's always good to learn several new angles from him. So congratulations, sir. And with this, I will now go on to my talk, which is positioning of newer anti-epileptic drugs in treatment of epilepsy. Again, this will be more of a conceptual talk in terms of new drug development, as we have seen over the past, over several decades, maybe closer to a century. And with this, I will just give you the concepts of how we go about deciding what drug to use, when to use it, older drugs versus newer drugs, what is the positioning, and so on. These are my disclosures. I've been a principal investigator on several of the new molecules. And the outline of the talk is there a need for a newer, better AED for epilepsy in general? And sometimes I will also look at childhood epilepsy in particular. What is the position of older AEDs? Are they being displaced really? The position of newer drugs, and these are the drugs that I'm going to talk about and end up with targeted therapies in epilepsy. Once epilepsy is diagnosed, we usually discuss with the patient and the relatives who are there about starting therapy. And at least if there has been a single seizure, with a good chance, more than 60% chance that the patient is possibly likely to get a second seizure based on the evaluation by the physician and maybe by EEG, then that is the new definition of epilepsy. Or if there have been 2 or more unprovoked seizures, then also that is the definition of epilepsy. And once we diagnose epilepsy, we always discuss treatment with the patients. And if we have to start the treatment, then we conventionally have been taught that usually it's good to start with monotherapy, use the drug of choice for that type of seizure. You try to classify the seizure, whether it's clearly focal from history, from EEG and other criteria. And if you're dealing with a clear focal seizure, try to use a drug that is useful for focal seizures. These are often narrow spectrum drugs which are used for focal seizures. Begin in monotherapy. If you think that it's a generalized seizure with no focal features, the EEG is suggestive of genetic generalized or primary generalized epilepsy, or sometimes if you're undetermined, you don't know whether it's focal or generalized based on these criteria, you would still start broad spectrum anti-epileptic drugs, and use the best drug for that generalized epilepsy. Whatever drug you choose, we choose in monotherapy, begin with a smaller dose that gives us a therapeutic range and gradually increase the dose till either seizure control is achieved or the patient shows some adverse events related to the drug, for which the patients have to be told about this and they should report back and we need to reassess. Having said that, if the first monotherapy fails, we think of using the second drug and add the second drug as we start, then gradually reducing the first monotherapy that has failed and go on to again increase the second drug to its maximal therapeutic effect or till you get side effects. Sometimes we might end up and try to reduce and remove the first monotherapy altogether, trying to be in monotherapy. Now, recently things have changed. People have started adding a second drug in a synergistic combination to take care that 2 different mechanisms of action that are synergistic are addressed for better seizure control. And sometimes even lesser side effects by adding smaller doses of 2 drugs that act on different mechanisms rather than increasing the supratherapeutic drug levels of a single drug, lead to then sometimes, so this is known as a rational polytherapy, and therefore, this is the concept by which we move forward in this. Having said that, having used those older drugs like carbamazepine, phenytoin, phenobarbital, valproate, and ethosuximide for absence seizures, there are significant number of patients that have not responded to this, and therefore there was need for newer anti-epileptic drugs, because either there were side effects of these drugs, the tolerance issues were there, or they were not effective. And therefore, a lot of new anti-epileptic drugs have come in. The difference here is that the conventional anti-epileptic drugs did not have any randomized controlled trials significantly. They just came in. Some of them serendipitously found to have anti-epileptic properties. Some of them are solvents. They suddenly found that they had anti-epileptic properties, started being used. So there were no really randomized controlled trials. But the new drugs have come in with a definite focus in mind. There have been some biomarkers or neurobiologic receptors and channels which have been described to cause epilepsy in animal models, and drugs have been tested on these models to find drugs that actually regulate these various mechanisms, and therefore the new drugs have gone through RCTs for therapy. Some of the RCTs have failed. For example, tiagabine failed, and some of them had serious adverse effects like felbamate and vigabatrin, and therefore are reserved for very specific indications where you have to actually apply, or in some countries you have to actually take a permission to use these drugs on very specific indications. But otherwise, we've got a nice spectrum of anti-epileptic medications, which are the newer medications, which is second generation, and now we have third generation medications, which are even more new and much more targeted to different targets. Now, in this whole gamut of anti-epileptic drugs, we didn't know how one fares against the other, and therefore there was a SANAD trial, that is a standard and new anti-epileptic drug trial. The first trial, which occurred about 20 years back, had two arms. The arm that dealt with focal seizures, which has carbamazepine, oxcarbazepine, gabapentin, and lamotrigine, topiramate. And the second one was generalized seizures, which was arm B, and which dealt with valproate and lamotrigine. And in this, it was found that there was not much difference. Carbamazepine and oxcarbazepine were very effective. Also was lamotrigine for focal seizures. Topiramate had more side effects. Gabapentin, although was well tolerated, did not seem to have very good anti-epileptic effects. Arm B showed definitely that valproate was superior as compared in terms of side effects in terms of efficacy to topiramate, and lamotrigine was equally good. Lamotrigine was very well tolerated. It had much fewer side effects than valproate. So this was the SANAD 1. Then came the newer anti-epileptic drugs and levetiracetam. And in SANAD 2 trial, which was presented last year in Bangkok in the International Epilepsy Congress, we have initial data from that for the generalized seizures. And here it was found that valproate versus levetiracetam, valproate is not non-inferior. Therefore, it was found that valproate is actually superior in many aspects, and which we will see a little later. Now, this whole new anti-epileptic drug development has given us specific drugs which is used in specific indications, like vigabatrin has been used in West syndrome, stiripentol and topiramate in Dravet syndrome. Lamotrigine has been found to be useful in absence seizures, and levetiracetam is found to be useful in myoclonic seizures, and perampanel in progressive myoclonic epilepsy. So this is what we have gained from looking for new anti-epileptic drugs. And this is a graph from Professor Brody's study, and he has quoted Chen in his JAMA Neurology article, which deals with the Glasgow experience of shift in anti-epileptic drugs over time. And if we look at this graph, we find that from the period of 1982 to nearly 2000 or so, you find that the older drugs like carbamazepine, valproate, phenytoin, and clobazam are finding great use. But as we move from the year 2000 onwards, with the advent of new anti-epileptic drugs, all these new colors have come in. That is the use of newer anti-epileptic drugs. Now, if you ask me, why has this shift occurred? Because we have started patient-oriented choice of drug. Besides just choosing on focal versus generalized epilepsy, we are tailoring it much further. So we have to look at patient factors like psychological, the physiological age, sex, weight, comorbidities, concomitant drugs, quality of life, and the stigma. Disease-oriented choice of the drug remains as before, like classification of epilepsy, whether it's focal, general, or undetermined, which you've talked about. And then specific syndromes that have been delineated, which we do in our practice before we choose the drugs, like localization-related syndromes and generalized syndromes, and then specific syndromes such as West syndrome, JME, Landau-Kleffner, etc. And all these make a difference in what kind of drug you're going to choose. And of course, it depends on EEG and other clinical features which contribute to our classification and understanding of the syndromes. Also, we have to then when we choose the drug, we always look at the pharmacokinetics and the pharmacodynamics of this. We have to look at evidence-based medicine. What is the clinical experience, the RCTs, what are the meta-analysis saying, drug use experience studies, pharmacogenomics. With the advent of now genetics and pharmacogenomics, we have to take that into consideration. We look at expert opinions, opinions of key opinion leaders in their experience of newer drugs, and of course, the overall clinical experience of physicians who have used this and your own clinical experience from your past use. So what happened? This is a snapshot of seizure, how much seizure freedom one gets with treatment from 1985 till today. Here we find that in the initial part, you found that the seizure freedom was only about 40% and uncontrolled were about 60% when we were dealing with the previous, the conventional drugs. Having added newer drugs, we found that the seizure control after adding any first drug, this is the Brody study, Kwan and Brody study, you get almost 47% response in the first drug. When you add a second drug, you have another 13% and so on, and a third and fourth drug, you have 4%. That leaves about 36% of patients who are still uncontrolled in spite of 2 or 3 drugs that have been appropriately used. And later on, towards the end of 2016, you still find that in spite of the newer anti-epileptic drugs, it still remains at about 36%, maybe 3 or 4% gain is there. So what has really not changed in spite of anti-epileptic drugs is the number of patients that give complete response to this, and uncontrolled is almost a third of the patients. So how do we choose the second drug? When we have finished using a monotherapy, the best drug of choice for that type of seizure, which is appropriately chosen, we look for different mechanisms of actions. We look for synergistic actions, which we have discussed, drugs effective for patients' comorbidities, and use drugs of high therapeutic index or that have a good tolerability profile. And again, this gives us, this chart shows us the comorbidities that may be there. There may be obesity where topiramate is useful, for example, migraine, again, where topiramate or valproate is useful. If you have depression or cognitive dysfunction, lamotrigine is useful, and so on. The SANAD-2 trial I briefly mentioned is actually an unblinded trial, but it's a randomized controlled trial which actually looks at levetiracetam versus valproate. It was found that in both the SANAD trials, time to 12-month remission and time to treatment failure were evaluated. But in the SANAD-2, there have been several other features that have been evaluated over here. It's found that valproate is found significantly superior to levetiracetam in all these trials, and also in time to 12-month remission. Therefore, again, this brings us to the positioning that valproate remains to be a good broad-spectrum anti-epileptic drugs. If we look at how the new drugs developed, there have been several mechanisms of actions, and many of you know this. This is the presynaptic and this is the postsynaptic membrane of the terminal. And many of the drugs like phenytoin, carbamazepine, lamotrigine, lacosamide, zonisamide, and oxcarbazepine act on the voltage-gated sodium channel. The SV2A receptors on the vesicles which are there, which are released into the cleft, synaptic cleft, and then act on postsynaptic membrane at AMPA, NMDA, and other receptors, the KNET receptors, are actually SV2A receptors. These are the levetiracetam and brevactam act on these receptors. Then there are the alpha-2 delta subunits of the calcium channel where gabapentin and pregabalin act. And there are drugs directly acting on potassium channel. Then also we have felbamate, which acts on NMDA, and perampanel, which acts on AMPA. Now coming to the SV2A, the normal synaptic transmission and vesicle recycling occurs in such a fashion that these vesicles are released, and SV2A is a protein which is integral transmembrane protein expressed in the secretory vesicles, And the modulation of this SV2A decreases synaptic currents in a frequency-dependent manner and reduces the readily releasable pool of neurotransmitter loaded vesicles. So if you look at 3 different models, one is a model of a drug naive or a knockout model, where if you have SV2A release from this into the cleft, there is a large amount of neurotransmitters that are relieved because there is no SV2A over here. Here you have SV2A protein that is affected by levetiracetam, which blocks the release and the level of neurotransmitters, which is known to be 10 to 15 times stronger in terms of SV2A involvement, actually brings down this neurotransmitters much better. So it's about 15 times more potent and in terms of its anti-epileptic effect. And after levetiracetam, brevaracetam has been the new molecule that is now currently available. And there is no head-to-head trial to compare levetiracetam with brevaracetam, but it has been shown by pivotal randomized controlled trials and real-world studies that brevaracetam worked even in patients who had failed on multiple drugs, and brevaracetam worked on patients who had failed levetiracetam. So both of these really tell us that brevaracetam is a good molecule. The most important, one of the important properties is that brevaracetam has got very high brain permeability, almost equivalent to the benzodiazepines, and therefore it penetrates brain very rapidly, gives its mechanism of action very rapidly. Within a day, you get this action. And if we were given an injectable preparation of brevaracetam, it would probably penetrate the brain very fast, and therefore it will probably find it's much better than phenytoin out here in terms of brain penetration, as you can see. And it may have a very good application in use in status epilepticus as a rapidly brain penetrable, which is again shown by here that there's a very rapid mechanism of action of brevaracetam as compared to levetiracetam, which builds very slowly. And again, in mouse models, which are radio labeled, you can find that brevaracetam ligand is displaced very rapidly, showing that it's very rapidly bound to the brain tissue. So it has a rapid onset of action. The most of the action starts and seizure reduction starts within 1 day itself. So almost 20% of the patients had more than 50% seizure reduction, which was sustained on day 1. How is this possible? As we have seen, rapid brain penetration and ability to initiate target doses without any titration. So that has been one of the fortes of brevaracetam, very rapidly acting, fairly well tolerated, and no titration required. As against the older drugs like lamotrigine, because of the propensity of skin rash in about 6% of patients, we have to titrate it very slowly. Topiramate, we have to titrate slowly, otherwise one would get a lot of cognitive side effects. And this has been the advantage of one of these. The other thing is that it is less prone to develop drug resistance because of PGP, absence of PGP interaction, PGP transport interaction. Therefore, sustainability and dropout rates may be less as compared to this. Here you can see rapid and sustained 50% responder status with brevaracetam. And in our study, pivotal study, we found that almost 84 months, which is close to about 7.5 years, over 7 years, the patients remained in the study and they showed sustained response. So it has been a good drug. The dropout rates are pretty low. Now, if you look at, does early add-on make a difference with brevaracetam? Now, if you look at this, this is a group of patients who have only 1 to 2 lifetime AEDs in this subgroup. And this is a group of patients who have had 5 or 6 lifetime AEDs in this subgroup, and they have failed these drugs. And when you add the brevaracetam to this, at 1 or 2 drugs or at 5 or 6 drugs, you find that there's a significant difference if you add it at 1 to 2 times lifetime AEDs versus 5 to 6 times. However, when you add to 5 to 6 times AEDs, you still find that if none is added versus if brevaracetam is added, there is almost a very significant response. So early add-on is fairly good, but current practice is to add on as a second add-on or third add-on. Maybe it will find its place as a first add-on in time to come with experience. We find that there is not major discontinuation because of side effects, about 5 or 6%. Somnolence and drowsiness are the major side effects. Does not have major behavioral side effects, as we can see. Now, does addition of brevactram bring down the number of ADs that the person is consuming. And if you find in this chart over a 12-month period that patients who are from baseline to 12-month visits, if you look at them, you find that the median number of AEDs at 12 months had come down from 3 to 2. Therefore, they were able to get rid of one of the 3 anti-epileptic drugs that they were using at baseline. Now, can we switch? What is the advantage of brevactram? Can we switch from levetiracetam to brevactram owing to intolerable behavioral adverse effects? So we see that a significant number of patients of levetiracetam have behavioral adverse effects, and you can actually switch them in the ratio of 10 to 1 or 15 to 1, and you can do an immediate switch, and you find that almost a significant number of them had no reduction, had a significant reduction in behavioral adverse effects, and they're also with showing no worsening of seizures. So it acts immediately, it acts rapidly, there can be immediate switching, and it can have a significant reduction of behavioral adverse effects, which are seen on levetiracetam. So these are dosage calculation, which I will not go into. This is based on body surface area for pediatric, but this for less than 20 kgs is about 0.5 to 2.5 mg per kg per day, and more than 20, you can look this up. It's available on the net and in some textbooks and so on. It has found pediatric use as well, and also in focal and generalized seizures. So I'll just skip all this. Coming to the next molecule very quickly, perampanel is a new molecule. It's a selective, non-competitive AMPA receptor antagonist. If you remember, on the postsynaptic membrane, there's an AMPA receptor which can be blocked, and it is used in partial seizures, 12 years or older. It is now approved for 12 years and older. Primary generalized tonic-clonic seizures, also 12 years and older. And this age will come down significantly as we gain more experience and more studies will be published. The important thing is that AMPA receptor pharmacology shows that it is a non-competitive blocker. Means what happens is the ligand binding domain is different for other molecules where competitive antagonists can go and displace this. Whereas when there's a terminal binding over here, the other competitors cannot displace this, and therefore it becomes a more permanent binding, and therefore a more permanent non-competitive block, which is an advantage. There are several types of glutamate receptors like NMD, AMPA, and KNET. I will not go into details of this. You all know that. And there's a tetrameric subunit structure of the AMPA, which is blocked by perampanel. And it has been found in vitro models that in several models of seizures, that it is effective except in absence epilepsy. So it's a broad spectrum except for absence epilepsy. And several studies have been done. These are the pivotal trials which have shown significant response of perampanel versus placebo. If you look at all the seizure types, there's a significant reduction in seizures. If you look at all seizures, if you look at seizures by type, simple partial seizures show good response. Complex partial seizure shows slightly lesser response, and secondary generalized tonic-clonic seizure shows a maximum response. So it's been used as a very good drug when you have secondary generalized seizures, and these secondary generalized seizures, which are often devastating, may cause injury, can be reduced quite well with perampanel. Now, if you look at all seizure types, again, by dose, you can find that 4 and 8 milligrams are quite as effective as 12 milligrams. Yes.
Hello.
Responder rate after 12 months perampanel, that is when you combine with other anti-epileptic drugs, it can be combined. If you have non-enzyme inducing AEDs, this is the response. You have a better response with that. But even if it's enzyme inducing AEDs, you have a slightly lesser but significant response. So you can combine with enzyme inducing as well as non-enzyme inducing AEDs. And again, if you look at this, this is responder rate of perampanel added to 1 to 3 non-concomitant AEDs, like you can add it to carbamazepine, you get a good response, valproate, you get a very good response. It can be combined with lamotrigine, and it can also be combined with levetiracetam to get a significant response as compared to placebo in different doses. And this is by doses. Most of the dose response are good at 4 and 8 milligrams. You can go up to 12 milligrams, but you should look out for side effects. The side effects may be psychiatric side effects are relatively low, but it may be seen in about 17 to 20% of patients and have to be looked for. But otherwise, significant side effects are not very much with perampanel. what happens here, what is shown in this slide, is that if you, the way you titrate it, you reduce it, reduce the number of side effects in general and also the psychiatric side effects. So if you titrate it, increase the dose at 2 milligram per week, which is a rapid titration, you probably get more side effects, including psychiatric side effects. But if you do it at 2 milligrams every 4 weeks or 3 weeks, then the number of side effects are significantly reduced. This is something that we have learned with our practice, and also this shown in this study. So overall, psychiatric side effects are only about 5%. Mood swings may be there. So it's not very much. Psychiatric side effects may be seen in about maybe 10 to 15% of patients if rapidly titrated, but if very gradually titrated, these values are less. So it has been found to be useful for idiopathic generalized epilepsy as well, and it could be useful as we saw in progressive myoclonic epilepsies. So I will skip this. And so what happened with newer drugs? In spite of having newer drugs, this has not changed too much, maybe 3 or 4% improvement in seizure control. And that brings us to what we still need. What we need now is treatment for therapy resistance, which is 1/3 of patients, as we have seen, treatment for difficult syndromes, more targeted and specific treatment for Dravet, Lennox-Gastaut infantile spasms, improved options for newly diagnosed patients, finding treatment that do not impact quality of life, modified release formulations which are easier to tolerate and take, and attention to comorbidities, which has not been looked at when we talk of anti-epileptic drugs so much. We have to look at what treats depression, what causes and treats depression, cognitive slowing, memory impairment. And of course, the most important is anti-epileptogenic or disease-modifying therapies. Because so far, these are anti-epileptic drugs, now recently called anti-seizure medications, because they only treat seizures, they don't treat the underlying cause of epilepsy. And therefore, we look at more targeted therapies. And here we have targeted therapies coming up in the last few years. These are, again, sometimes for rare epilepsies, but we are beginning to understand the epileptogenesis in some of them. Like tuberous sclerosis complex, you find that there's an mTOR pathway which is affected, and there are anti-mTOR drugs, anti-mTOR blockers. For Dravet syndrome, some new drugs have come up. For GLUT1 deficiency, we have seen that SLC2A1 gene has been found, and ketogenic diet and triheptanone has been targeted to use. CDLK5 is an X-linked related cyclin-dependent enzyme which is blocked on one of the X chromosomes. And there are studies that show that unblocking of the second X chromosome, where a normal CDLK5 gene is, can actually cause reduction in seizures and improvement in, and then there have been studies on Rett syndrome and Lennox-Gastaut syndrome. So to end the talk, let's look at 2 or 3 of these therapies just as an introductory to the targeted therapies. So we have seen that Dravet syndrome is very significant in some children with febrile and afebrile seizures and poor outcome. They could have some movement disorders, and therefore they found that Epidiolex, which is cannabidiol, has been used in this to form significant improvement in seizure control. We have to remember that cannabidiol actually has some drug interactions when clobazam is going on along with that. And what it does is it increases the level of clobazam as well as the norclobazam significantly. And this has sometimes given beneficial effect in reducing number of drop attacks. But sometimes if you miss the dose of cannabidiol, or if you are going to change the dose of clobazam, this can cause devastating effects, which should be known. And again, the second drug that has been very commonly used, not in India, but abroad, especially in France, is the stiripentol, along with valproate, to take care of the seizures in Dravet syndrome. And it is found that adding cannabidiol to stiripentol actually increases the level of stiripentol by 55%. This is all related to the enzymatic effects on the liver and cytochrome system. And one has to remember, although in clinical practice, this 55% rise in stiripentol is not very significant, one has to remember this. So we have found that for convulsive seizures, cannabidiol is useful as compared to placebo. and also for total seizure, that is convulsive as well as non-convulsive and drop attacks. So this is a new drug which has been used and approved for also, it has been approved in Lennox-Gastaut syndrome, where it has also shown changes in drop seizures and non-drop seizures. About tuberous sclerosis, everybody knows that the manifestations of tuberous sclerosis are many. And here we look at this revolutionary everolimus for seizures associated with tuberous sclerosis called EXIST-3 trial, where different doses of everolimus have been used as compared to placebo and found to be effective in doses of 3 to 7 nanoliters and 9 to 15 nanoliters. Both the doses were effective as patients were randomized to 3 groups, and it has shown significant response, as you can see, at different drug levels of this drug and in different seizure types, focal motor seizures and others. Another new drug which has come is the cenobamate, which is used for uncontrolled focal seizures. And this has been again studied in this study, in which several doses have been used up to 400 milligram per day and found to be useful. The placebo as compared to placebo 200 and 400 have found significant improvement in increasing quantities over here in this, and in the maintenance phase also it has been found both in double-blind and maintenance phase. What is important is that 75% responder rate has been quite high at 46%, and 100% responder rate has also been very high. And this is one of the highest 100% responder rate and complete seizure freedom rate seen with the newer anti-epileptic. So it remains to be seen how good this drug is, when it will be available to us, and we will wait for more post-marketing response for this. Seems to be a very promising drug. Fenfluramine is a serotonin 5-HT releaser with agonist activity of 3 of the several 5-HT sub-receptors. It has been used as a weight loss drug in the past, but because of pulmonary hypertension and cardiac abnormalities, it was given up, but now again found to be very useful in the Belgian open label study of Dravet syndrome, which is affecting SCN1A mutations. And here it has been found that fenfluramine has been found to be quite effective in controlling 50 and 75% seizure reduction in patients of Dravet syndrome. And in some of them, we've even got seizure freedom up to the level of 17%. So with this, I come to the end of this talk. I have covered in concept what are the anti-epileptic anti-seizure medications, and then what really is anti-epileptogenic or targeted therapies, and then how this new drug development took place, why it took place, how do we choose the drugs, what is the positioning of the old drugs. They're still very good, they're still effective for us, and how the newer drugs have found much better tolerability, more targeted use, different mechanisms of action, different tolerability profiles to be used in patients with comorbidities. And that brings me to the end of my talk, which talks about what are the barriers to use, understanding of epileptogenesis and the disorder as such, contribution of factors such as genetics and environmental, availability of the ASMs or advanced target therapies, especially not only in developed countries, but in developing and poor countries, the costs of therapies, and the comorbidities that need to be treated to ensure normal development. Thank you very much for your attention. I think I will stop sharing my slide and hand over to Dr. Joy.
Thank you, Dr. Ayadi. And I think question and answers are probably going to be at the end of the session. We are anyway running behind time, so I'll not stand between the audience and Dr. Vinayan. So it's my privilege to invite Dr. Vinayan to speak to us today about pediatric epilepsy. Dr. Vinayan is the professor and head Department of Pediatric Neurology at Amrita Institute of Medical Sciences, Cochin. He both nationally, internationally, and in epilepsy organizations across the world. He's a very enthusiastic advocate for rational therapy for epilepsy and epilepsy patient care. and academia. And I'm sure everyone will learn a lot from listening to Dr. Vinyan today. So he's going to talk to us about rare and interesting cases in pediatric epilepsy. Dr. Vinyan.
Good evening. Thank you, Joy, for that introduction. And I am very fortunate to be here today on the book launch of Chakraborty on the seizure mimics, because that is one of the most important things when we are dealing with epileptic seizures. So my topic today is rare and interesting cases in pediatric epilepsy. So I would like to confess here is that what there is, I don't know, but how can we define what is interesting cases, which is interesting for me may not be interesting for you. And so, and the rarity also depends on what you see in your practice. See, something like a neonatal seizure may be very rare in Joy's practice, but that is the bread and butter for me at this point. So it depends. So what I'm trying to do is, when I think of these cases, see, over the years, it has stuck, or it is or some case which has taught you something, or which has challenged you, or it is a kind of a curio. It's something like we have not seen it before, or I have not seen it. So it is that kind of four cases I am trying to show you, and I will you don't have to be worried, because whenever a pediatric epileptologist wants to show rare and interesting cases, Joy will run away now, because he expects it will be all of metabolic, genetic, this thing, that thing, so with no relevance to the practice. So maybe I have tried my level best to avoid that here. So with this, this everybody knows. So this is the kind of the algorithm which ILA proposed, and it is a very clinically useful thing. So the book which we have released today is primarily at this level, where you have to identify whether it's seizure or not, then only it all comes. So the rarity, but I am trying to see something like an interesting case is an interesting semiology, or an interesting type of seizure, or it is something like a seizure mimic which looked like a seizure, as Joy was trying to say, or the other way around, a seizure which is initially looking like a non-epileptic event. So what I'm trying to do in the next four cases is something like an unusual, that will be the whole interest, and what I learned in that case, and something like a learning point for some of you in the audience. So this is I think this case I saw around maybe 12 years back. So it is an 8-month-old boy who was completely normal initially, and he came to me with very resistant spasms from 7 months of age, a kind of a very garden variety of spasms, and EEG showing hypsarrhythmia. So very, very common in a pediatric epileptologist practice. But I was surprised to see the MRI, because I was expecting some kind of a normal MRI, or at least a kind of an, even though we don't get a clear history of HIE, sometimes, many times we get a posterior loss of or oligaric picture, or some kind of corpus callosal hypogenesis, or a kind of atrophy or hypertrophy, but or a kind of term HIE seculae, or something like a cystic encephalomalacia, anything. And so something which is classical. But what we saw here was a kind of very localized insult, which is not looking like a vascular insult. So it was more looking like a post-traumatic effect with, I'm not showing the susceptibility weighted image. There are some blood products also. And it was not looking like a traumatic, a kind of battered baby also, a shaken baby syndrome, which is having a different kind of the MRI picture. So this is more looking like a kind of hemorrhage and a contusion, and then there was no history of trauma in this child. So an apparently normal child, and who had an undetected trauma. And then I had to dig into the history, and that history. So this is the MRI again, showing that a kind of gliosis and cystic changes, which was very localized. And the EEG was having a focal spike, but it was more like a hypsarrhythmia with an asymmetric kind of an hypsarrhythmia with a focal spiking from there. And subsequently, the patient, once we had the treatment of the spasms, the EEG got more localized to this region. So further images. Okay, so why I showed this, the coconut trees here. So, you know, the Kerala where I am staying is, yeah, so it's a land of coconut trees. But even with that, I have not seen an infant coming with this kind of history. So the history was like a kind of this immature coconut, the unripe coconut was had the child, one mother was carrying the child, and there was this small one. Actually, it was much more smaller than this. This is a Google photograph. This is not the photo. It was never taken even to the hospital. Child cried for some time. This fall on the child's head, and child cried for some time, and then it was and then there was no vomiting. There was no acute thing. They didn't take an acute care of. They didn't take into emergency also. So, but unfortunately, the child developed a significant, probably a bleed with a vascular injury in that region. So, I'm yet to see another child. So, the only thing is, even in Kerala, this is very rare. So, a rare cause of post-traumatic epilepsy in infancy. Okay, so that's the rarity here. So, nothing more, nothing less. There is nothing to study of in this case, but you have to think of unusual causes. Probably even small injuries at that age can produce significant insult to the brain. So the second case is 1.5 months old. Again, I'm trying to put it everything in infantile period probably. So again, showing the rarity of those cases. 1.5 month old boy from Maldives. He actually came to us with recurrent seizures starting in early infancy. That means almost like early infantile epileptic encephalopathy with multiple types of seizures. But there was a clear localization. It was more like seizures are originating from the right side of the brain. There was a left tonic seizures of the hand, then generalized tonic seizures, asymmetric tonic seizures, and it was a typical epileptic encephalopathy with clearly we can say that there was a structural, clinically itself, semiologically, there is a possibility of a structural lesion on the right side of the brain. So you know that whenever we have such a case, we think of the common pathologies like focal cortical dysplasia or a hemimegalencephaly. So all these things are fairly common in this kind of age group. And the only history in this case was a little curious history was the elder child also had developmental delay. He also has got left hemiparesis and seizures from early infancy. And he is getting very frequent focal seizures. And this child has been treated as a congenital CMV because there was some calcifications in the brain. And also a first cousin, there is also a history of hemiparesis and focal seizures. But unfortunately, we have not seen these children. But historically, there are similar cases in the family. So then if we take this takes us into some genetic syndrome, it's very clear. So there is something hereditary in the family. So unlikely to be an infection. So, but in CMV, as you know, if you have very close contacts in the family and if they are staying together, even CMV can run in families because a child with a congenital CMV can infect multiple expectant mothers. So examination just proved that an epileptic encephalopathy with a left-sided hemiparesis, multiple seizures, and they came with a CT scan. CT scan showed calcification in the periventricular region, and there was vessel calcifications also. And this has been, again, this child also was treated as congenital CMV from Maldives, and child was on phenobarbital before coming here. So EEG is a multifocal abnormality, but right hemisphere was suppressed. So again, suggesting that right hemispheric abnormality is there structurally, which is there. So this is the MRI. So this is the MRI which showed definitely there is a right-sided hemiatrophy, and there is volume loss and multiple small cystic phases. But what is striking is the left side is also not looking normal. Left side is also atrophic. So not only the right side is atrophic, but it is affecting the left side of the brain also. So where are we? See, if you look at the etiologies, we have, it is a structural disorder. It can be an infectious structural, or it can structural. So it is something like a kind of structural abnormality which is affecting both sides, but more on the right hemisphere. So we did, because of that hemiparesis, we never usually do an MRA in a usual day-to-day epilepsy practice. But because there was some suggestion of small infarcts like things, so we planned an MRA also in this child. And for our surprise, you can see that there is a cutoff of ICA and all the major vessels, and the vessels are reforming later. So there is an early signs of moya. So moya, you know that it's a syndrome or it's a disease, because if you have a cause, then we will call it as a secondary cause. It is a syndrome, but otherwise it's a moya disease. So you have many genetic disorders described now. There are standard genetic disorders like neurofibromatosis, and even CMV is a congenital cause for congenital moya. And you have diseases like sickle cell disease, which can present like this. So the familial moya is also described, but it's very rare. And then there are very few reports this genetic study in this patient, but the child went in for revascularization, but genetic study was not done. The patient went back to Maldives, so we were not able to follow up this child. But the moral of the story is you can have rare vascular disorders, vasculopathies, which may look like moya, or you can have cerebroretinal vasculopathies also starting at that age due to infectious vasculopathies or genetic vasculopathies. So coming to case 3, this is a very recent case which I have seen during the COVID times. So a normal child, elective LSES, no perinatal distress, seizures on day 4. So 101 reasons when you have a neonatal seizures on day 4. And the child is not encephalopathic initially, but child received to initially levetiracetam and then phenobarbital. So the type of seizure, so I felt like it is a myoclonic seizures, but then it evolved into multiple types of seizures, and it was more like a multifocal clonic seizures. You can see here, this is the video of the child. So you can see you NICU, you can see that clonic seizures affecting different parts. So initially it is in the left fingers, and then you have proximal movements, and along with that you have some kind of respiratory abnormality. When you have a clonic seizure there, it is according to the recent neonatal seizure classification, you are pretty sure you are dealing with a seizure. So if you have a hemiclonic seizure,
have we lost him? Connection?
Rahul, what is update?
Yes,
Rahul?
sir. Yes, sir. Yes, sir.
We have lost, sir. I think some connectivity
No, no,
issue.
there is some connection issue. Yeah, yeah. Let me reach him. Yeah, yeah. Just.
So it is 9 a.m. with Nandan.
Yeah. No, it got disconnected. I'll connect it again. That's it. It came again. Okay, sorry. So I'll share the screen again. Sorry for that. Can see the slides now?
Yes, we can.
Hello?
Yeah, we can see.
Yeah, okay. Yeah. So anyway, what I was trying to show you is that there are multifocal seizures. So I'll stop it and then move on to the type of. So what we are seeing is a kind of multifocal clonic seizures in a neonate. So the DDs, you can see that there can be the etiology, it can be genetic, structural, hypoxic ischemic. So according to the recent ILA position paper on neonatal seizures, where I was fortunate to be part of that. So this is the etiology in the neonatal period. It can be hypoxic ischemic, it can be due to a structural vascular event, and unlikely because it is multifocal. So when you have a multifocal clonic seizures, the commonest is genetic metabolic. But very rarely you can get infections, but in a normal child, infections are very, very unlikely. So this is the EEG. It showed multifocal spiking in the interictal period, seizures coming from the right side of the brain here, and then it evolving. It's one seizure, and then the seizures coming from the left side of the brain. And again, it can come from both sides at different frequencies. So I'm not going to the details of neonatal seizures and the technical things of that. This is the MRI. So in one look, it looks normal. This is the T2 images. And but if you look at the diffusion weighted, you can see multiple white matter hyper diffusion restricted areas, which is correspondingly ADC showing corresponding black areas. So this is all throughout the brain, and different, even thalamus is involved, the corpus callosum is involved. So what's it? So in a normal child, the child is not in, the CSF was normal. They have done, the pediatrician has done the CSF already. So the probing further, so I was not very sure. There are some metabolic disorders like the maple syrup urine disease, but they never present with a normal child like that. And only history was the formula fed on the first day. There was a mild jaundice, occasional loose stools on the third day before the seizure occurred. So the Google helped. So there is a definite pattern of these similar injuries described with neonatal rotavirus infection. So you see, this is the published report, which is looking very similar to the case which I have shown. And other studies, which is again showing multiple, you can see the specifically symmetric white matter hyperintensities with the diffusion restriction, and mostly diffusion restriction, which may go into a kind of mild atrophy later. So that has been proven. So we did a stool rotaviral sample, it was positive, and the advantage is you don't need a lot of metabolic studies if you are proving this. So unless otherwise there is the immediate DD is a metabolic disorder. So this child, the response is really good in the initial phase. If you treat well, there is no need for multiple anti-epileptic drugs. It is more like a benign neonatal non-familial seizures. Okay, so the case 4 is the last case. So pediatric epileptology is not complete without a genetic cause. So this is a 5-month-old boy, normal birth and development, clusters of seizures starting at 5 months of age, prolonged DTCS, multiple hospital admissions. So no dysmorphism, no focal deficits, MRI normal, EEG normal, routine EEG. And metabolic studies, they did everything non-contributory. So if this is the situation, you have to think of genetic epilepsies, especially the early onset epilepsies, the sodium channelopathies, because this is the age group you will get. The classical example is Dravet syndrome. So genetic, you have a lot of causes. I am not going to the details, but if you have a normal child, normally developing child, multiple types of seizures, multiple admissions, a sodium channelopathy, especially 6 months, 7 months of age onset, and if you have some relation to febrile illnesses, you have to think of a sodium channelopathy. Commonest is Dravet syndrome, SCN1A syndrome. So if anybody who wants to read about this is, I will recommend you to a recent free publication from Epilepsia. It is December 2019 by Renzo Guarini and Rimanabu, the doyens in the field. It's written about Dravet syndrome and other sodium channel related encephalopathies. So which are the other sodium channel related encephalopathies? So that you will have to know. One is SCN2A related disorders. So the thing is, SCN2A related disorders usually presents in the newborn period, but they usually present as benign familial neonatal seizures, but sometimes it can present with other epileptic syndromes like developmental epileptic encephalopathy or an Ohtahara syndrome. But the age group was, in our case, the age group is not fitting well for an SCN2A syndrome, but sometimes it can present later, but usually they present early. So the other one is SCN8A related disorders. So this is the sodium channelopathy, which can present almost similar time as Dravet syndrome. So the advantage is, or the difference between Dravet syndrome and the SCN8A disorders is SCN8A related disorders are exquisitely sensitive to sodium channel blockers like carbamazepine, phenytoin. This works well. So many times the practice in pediatrics is they give a dose of phenytoin and then they will not continue with phenytoin after a cluster of seizures. So then the child comes back. So this child had the same episode. So multiple episodes they were given in pediatric, general pediatrics department. They have given injection phenytoin during that acute cluster of events, and then they rapidly withdraw phenytoin. So that again, the seizures comes back in this kind of disorders. So the classical presentation is benign familial infantile epilepsy, but they can present with other types of epilepsies also. It can present with a severe developmental epileptic encephalopathies. So you can see the difference. Again, I'm not going to the details of this, but to summarize things, this child had SCN8A mutation. Okay, so what is the significance? If you see this SCN8A mutation, the thing is you have to hike up the dose of a sodium channel disorder, a sodium channel antagonist. So what we did was we increased phenytoin and continued valproate and clobazam, and then the child responded to that for 3 months. But again, came back. The moment I started withdrawing valproate, child came back with a flurry of seizures. But that was definitely, when you have that kind of an episode, you have to ask whether there was a missing dose of phenytoin or any of the, in this case, the child had spit out 1 dose of phenytoin. Even with 1 dose of phenytoin spitting out, they can get flurry of seizures. And then we documented that phenytoin levels have dropped very drastically at that point. So the thing is, it is not new. I am not telling you a new thing, because in many cases with SCN8A related epilepsies, they have shown this. These children needs a very high dose of phenytoin in their system so that the seizures will not occur again. So what we did was we increased the dose of phenytoin and then try to keep it at a higher level. So, but you have to check whether the patient is having side effects, because sometimes the small children can go into phenytoin encephalopathies. So you have to be careful with phenytoin therapeutic drug level monitoring of phenytoin. So the bottom line is say the genetic epilepsies or genetic diagnosis is not for the next baby or not for a kind of for the physician. So it will help you to manage the child. So like in this case, or many other targeted therapies are coming. So in undiagnosed cases of pediatric epilepsies, difficult epilepsies, you have to do a genetic study. That's the message I would like to give. And with this, I would like to stop. And if there is any queries, we can take at the end. Thank you.
Thank you, Vinay. You thought that we would not enjoy it, but actually, I can assure you, we all had a great time. So I thoroughly enjoyed the cases that you showed. Michael was to run the question and answers. And Michael, do we have anything or?
Sir, we don't have any questions. I just went through the questionnaires. Everybody had complimented. I have got plenty of compliments, but no doubts as such.
Super. So do you want to propose the vote of thanks, Michael?
Yes, sir. Sir, very good evening. Once again, sir, I take this opportunity to all of you who have participated in this webinar of a virtual book launch, Mimics of Epileptic Seizure by Professor Ambar Chakraborty. And 3 topics were selected. They were also very apt on the occasion by Dr. Joy Desai, Dr. Nandan Yardi, and Dr. K.P. Vinyan. And unfortunate part that we couldn't, that Sangeeta Rawat was not present because of her father demise. We missed, and she was architect of this program along with Dr. Joy Desai, Nandan Yardi, and K.P. Vinyan. I wish all the success for this book, and I request my STR team, they make it sure that this book is available to all PG, all institution, and all younger neurologists. And wherever demand come, we should present this book, and we should make this book a big success. So with this note, sir, once again, thank you very much, sir. Dr. Arnab Chakraborty, sir, Dr. Joy Desai, Dr. Nandan Yardi, Dr. Vinyan KP, and of course, my team, Michael, Chinmay, Rahul, and Hemal, who were present during the occasion. And I'm sure we will get more opportunity in times to come where we can meet more frequently for this academic course. Thank you very much, sir. Thank you all the delegates for sparing your valuable time, sir.
Thank you, everyone.
Thank you very much.
Thank you.
Thank you, Joy.
Bye.
Stay healthy, stay safe.
Bye, sir. Thank you,
Bye.
sir.
Good night.
Bye.
Thank you so much, sir.
Thank you. Thank you
Thanks,
so
sir.
much.
Thanks, everyone. Thanks. Bye.